Assalamu alaikum. I'm Dr. Misal, resident microbiology department, and today's topic is clinically significant yet overlooked infection, listeriosis. And the title is Listeriosis and its clinical relevance and rational therapy. So, listeriosis is a bacterial infection most commonly caused by Listeria monocytogenes. Coming towards its history, the first cases of human listeriosis were reported in 1929 in Denmark. However, the first recorded culture of Listeria monocytogene dates from 1921 in France. In 2002, a seven-state outbreak was linked to deli meats and hot dogs processed from the same plant in United States. So this is infectious cycle of listeria. Listerial infection is a foodborne bacterial illness that can be very serious in pregnant and immunocompromised women. Uh, Not women, immunocompromised human beings. So starts with the ingestion of contaminated food like raw vegetables, contaminated animal meat, unpasteurized milk, and it enters the gut mucosa via internellins, and there it enters enterocytes and M cells of pair patches. Then the seeding towards the lymph nodes occur. From lymph nodes, it can evade the local immune response in immunocompromised or pregnant patients, and the bacteremia occurs. From bacteremia, the dissemination towards the organs can occur. So coming towards the virulence factor of Listeria, we have henolysin HLY gene, which encodes for listeriolysine, which helps evade the phagosomes. Then we have ACT-A gene, which encodes for ACT-A protein, which can help from spread from cell to cell. Then Listeria also has metal ion channels. We have P60 protein, which encodes for P60. We have P60 gene, which encodes for P60 protein, which helps in adhesion and cell division. We have phospholipases, which helps in degradation of host cell membrane. And then we have internellin A and B, which helps enter endothelial and epithelial cells. So this is microbiology of Listeria. It is a facultative anaerobe, non-sporulating, gram-positive rod, temperature and salt tolerant. It is motile at low temperatures. So this graph indicates annual cases and crude incidence of listeriosis reported in England and Wales. On y-axis, we have incidence rate per 100,000 population, and on x-axis, we have years like 2013 to 2022, and we have confirmed cases of listeriosis. We can see in 2013, the incidence rate was 0.28 and the confirmed cases were 160. We can also see the fluctuation in the graph. In 2016, the cases were on its peak, but in 2020, the reported cases were lowest. That can be due to pandemic-related reporting or change in food handling. So this is epidemiology in Pakistan. Listeria is officially underreported with sparse case series. 6 human cases were reported in Karachi in a local tertiary hospital in February 2023. A 1993 report showed the first documented human case in Pakistan. So, coming towards the foodborne prevalence, especially raw milk, in Faisalabad in 2012, 400 samples, the prevalence was 2.25%. In Hyderabad in 2007, the prevalence was 6 to 12%. So this is local cases of listeriosis in Chughtai lab in 2024. 24 confirmed cases of Listeria monocytogenes were detected. The 7 were isolated from CSF and 17 were isolated from blood cultures. Coming towards the clinical manifestation of listeriosis, there are 2 types of listeriosis, non-invasive and invasive. Immunocompromised group and individual with pregnant women and neonates are at high risk. So non-invasive form is also known as febrile listerial gastroenteritis, a mild form of disease affecting mainly otherwise healthy population. The symptoms include diarrhea, fever, headache, and myalgia. So this is the invasive form, which is known as more severe form of the disease and affects certain high-risk group of population. These include pregnant women, immunocompromised patients like AIDS, organ transplant patients, and elderly people and infants. The symptoms include fever, myalgia, septicemia, meningitis, and raw encephalitis. So this is a case scenario. A 30 years old pregnant female, gestational age 26 weeks, presented with low-grade fever and flu-like symptoms for 2 days. associated with nausea, diarrhea, and myalgia. She has mild abdominal cramps and loose stools. She ate unpasteurized soft cheese and deli meat at a social event 8 days ago. There was mild leukocytosis, CRP elevated, LFTs and RFTs were normal, blood culture and stool culture was sent. So, what is the diagnosis? So, it's listeriosis in pregnancy. So it is common in third trimester. Infection can lead to miscarriage or neonatal sepsis. The common symptoms include gastroenteritis and bacteremia with fever, muscle pain, back or abdominal pain, diarrhea, and vomiting. So this is diagnosis and management in pregnant female. If the fever is more than 100.6 degrees, we send the blood culture and stool culture. Then we treat it with parenteral antibiotics until the cultures return. If the fever is less than 100.6 degrees, we send the labs and manage it with oral antibiotics with clinical monitoring. This is a pie chart of pregnancy associated cases of listeriosis in England and Wales. In this, we can see there were 62.5 live births and 4.2 stillbirths with 20.8% reported miscarriages and 12.5% were unknown outcomes. This is another case scenario of 5 days preterm baby, weighs around 2.5 kg, born in a normal vaginal delivery with immediate cry. He presents with poor feeding, lethargy at day 8 of life, decreased activity, irritable, and has fever at 38.5 degrees. Mother had flu-like illness at 26 weeks of gestation. Anterior fontanelle are tense and full. So what is the diagnosis? It's neonatal meningitis by listeria. So, intrauterine transmission can result in fetal demise. Neonatal infection often manifests as early onset sepsis in the first week of life with high mortality rate in premature infants. Late onset infection typically presents as meningitis. Coming toward the blood investigations, we have CBC where there is leukocytosis with neutrophilia in maternal or neonatal infection. CRP and procalcitonin are elevated. Liver tests may be mildly deranged in maternal cases but not very significant. So microbiological diagnosis, blood culture is a gold standard for diagnosis. Listeria monocytogenes is often recovered from blood culture, grows in standard aerobic conditions. Its colony morphology is as such grayish-white to translucent colonies with narrow zone of beta hemolysis. In biochemical tests, we have catalase positive, oxidase positive, and shows tumbling motility at around 20 to 28 degrees or weakly motile at 37 degrees. And CSF analysis is very important in diagnosing meningitis. It has turbid appearance. Cell count is around 100 to 1000 per millimeter cube. Lymphocytic or mixed predominance, increased protein and decreased glucose. In gram stain, there are small gram-positive rods. Imaging is important in neonatal meningitis because we can rule out hydrocephalus, brain abscess, and infarcts. PCR is very important. It detects listerial DNA in blood, CSF, or amniotic fluid. It is faster than culture and is highly specific and sensitive. In general treatment, we have first-line antibiotics, ampicillin or penicillin G and gentamicin. They are used in combination in CNS infection for 4 to 8 weeks and in bacteremia for 3 to 6 weeks. So this is treatment for pregnant women. In empiric management, start antibiotic if the patient is exposed to high risk or recalled food and fever is more than 100.6 degrees and the patient has flu-like symptoms. The empiric therapy is IV ampicillin. If mild symptoms and afebrile, then we go for oral amoxicillin. So this is blood culture based management. If the culture come back positive, continue with the IV ampicillin. If the culture comes back negative but there are no alternate diagnoses, then we go for 7-day oral therapy. So these are the alternate antibiotics for listeria. So patient with penicillin allergy, we go for trimethoprim sulfamethoxazole, but it should be avoided in first trimester or last month. Meropenem is also an option. Vancomycin only if no other option is available, and linezolid has a limited data or toxicity risk. So coming towards the prevention of listeriosis, there's a general recommendation for all individuals: only eat soft cheese made with pasteurized milk. Even pasteurized cheese can be contaminated during production. For hot dogs and deli meats, avoid juice contact with other food or surfaces. Wash hands after handling. Store unopened packs for less than 1 week and open pack for less than 1 week and unopened for less than 2 weeks. Sliced deli meat used within 3 to 5 days. Seafood should be used canned and shelf stable tuna. Avoid unpasteurized milk products made from it. Always store milk at 4.4 degrees. Extra precaution should be taken in every high risk group. Avoid all soft cheeses until certain that they are safe. Do not eat raw sprouts or lightly cooked sprouts. Avoid avoid meat until they are heated to 167 degrees or steaming hot. So these are key points. Always use pasteurized plus refrigerated milk, which is safer. Cook sprouts and deli meat thoroughly. Hygiene and storage are critical because they can cause cross contamination. So these are the references I use, and thank you.